Hi guys, in preparation for your visit or as a little reminder from the previous visit, I wanted to film this video kind of to put things together and help you organize your thoughts. So here we go. Um, First of all, let's talk about lipedema in general. I'm sure you already have done your research and you know what lipedema is. So lipedema is a connective tissue disorder, if you kind of believe that, and associated with excessive accumulation of fatty tissue in the lower half of the body. And it usually involves the areas from the waistline below. At the later stages, it can also involve the arms. We do have some patients that come in with the breast issues, but I think at this time it's not really formally recognized. I'm not going to go on different stages. You can see the stages online. So the question is, what do we do with this thing? As you know, the lipedema starts at puberty and usually gets worse during the anytime when you have hormonal spikes. It could be pregnancy, it could be birth control pills, could be IUD. I've seen the patients become significantly debilitated with lipedema after removal of suppressant medications, after chemotherapy, after Lupron, not on Lupron, but after Lupron is off. And then finally, it really gets worse during menopause. And what happens is that usually the ladies have thicker legs, which are usually painless at that time. At puberty, they get bigger. They stop playing sports. The parents usually push on them and tell them they need to lose weight, start doing diet and exercise. And eventually they get frustrated because nothing works. And they kind of accept their Italian, Jewish, Arabic, Hispanic, whatever genetics you attach, legs as a permanent result. And then you usually look back and you see that maybe your mother, grandmother, or somebody else in the previous generations had the same legs. So it's well accepted. And as long as there is no pain, most people don't do anything about it. Usually in the mid ages, usually that's where I see the patients with significant disease, when they're tired, when they're frustrated, when they've seen multiple doctors who cannot help them. And I have to say the education about lipedema, as you understand, is lacking behind, and majority of the medical community is not really aware of it. So average time to diagnosis is about 15 years, believe it or not, which we're trying to change, but it's a very frustrating process for us too. The fact that you already found us means that you're already ahead of 99% of lipedema patients who are out there. Now, now you have lipedema. The clinical symptoms, as we said, are bigger legs. Usually the fat continuously gets worse. You have pain. About 63% of the patients do have pain. You have easy bruising. You have hypersensitivity of the skin. Some patients, for example, don't like when the baby lays or a pet lays on their lap, or if the arms are involved, they're really sensitive to blood pressure checks. And a lot of patients feel that this is normal. This is the way they lived all their life, and they think most of the women experience the same symptoms. But reality is they're not. A majority of women do not. So the ladies with lipedema have accepted all this pain and discomfort as a part of their life, and I give them the credit, but really it shouldn't be this way. Now, I'll give you a story. One of the ladies came in and said that she had a granddaughter, and she really thought that granddaughter was biting her all the time whenever she would lay her head on her lap. Reality is the granddaughter was just laying on her lap, and that's all it was, but the pain was such that she felt as if she was getting bitten. What to do about it? Obviously, the surgical treatment is not the first line of treatment, even though it's one of the most effective ones. So online, you've seen Mediterranean diets, low-carb diets, anti-inflammatory diets. We're talking about protein, we're talking about salmon, we're talking about avoiding gluten and white flour products, no high-salt diets. We're talking about high water supplementation, taking additional supplements like selenium, like vitamin C, like vitamin D, vitamin B6, vitamin B complex, and then using other methods such as dry brushing, manual lymphatic massage, compression garments, mechanical compression pumps, vibration plate, aquatic or water exercises. And as the composite, it really can improve the pain and discomfort. The issue is that it's only temporary, unfortunately. You've done pumping, usually feel better. Several hours later, the pressure is usually partially at least returned. And unfortunately, in time, it's getting worse. So now the question is that liposuction is usually one of the most definitive or long-term effective treatments for lipedema. But based on the current definition of lipedema is and how it works, it's not clear what does liposuction really do to make your symptoms better. And that's what I've been struggling with. It's kind of, we know the treatment works, but we don't quite understand why. So I had to put all of it in more of a physiologic perspective. What I'm just about to tell you right now may not be something that everybody agreed to. So I'll warn you right away. So if you're a provider or you do lipedema, you may or may not agree with my physiologic approach. But as you listen, hopefully it'll eventually make sense. So let's step back for a minute and look at overall physiology of the tissues and then put overlay of lipedema on top of it. So as the body delivers nutrients and oxygen to the tissues, it goes through the arteries and it's pushed by gravity and by pumping heart. Now, once the body receives all the nutrients and oxygen, it releases waste products. And the waste products have to be returned back to the heart. It's easier to do it from the head because the gravity helps, but it's unrealistic to expect from the heart to suck all the blood from all over the body back to the center. So the body has developed the systems to help itself out to pump the blood in. All the waste products, just like your local recycling company, are divided in two categories. One, that are small in size and water soluble. Those byproducts are absorbed or filtered into the veins. And then through the venous system, it goes back to the heart. And then it's cleared in kidney and liver and so forth. And then the products that do not fit that category, they go into the second system, which is lymphatics. And lymphatics have the same overall structure as the veins, but they're significantly smaller and the walls are significantly thinner to allow those oversized particles to get into the blood vessel and then get pumped up. Now, what happens next is as you walk or you move or you squeeze your legs in some form of capacity, the veins and lymphatics get squeezed between the fascia, skin, and the underlying muscle. And that pressure creates increased pressure inside of the blood vessel, vein or lymphatic. Now, obviously, when you squeeze on the vessel, the blood can go either up or down. The body has one-way valves that close in one direction. So when the pressure goes up, the valves close and it pushes the blood or the lymph upwards. And as the process continues, that's how pump works. Now, as we get bigger, as we get older, as the veins and lymphatics stop functioning normally, what happens is that the vessel gets bigger or wider, but the valve stays the same or just stops working normally. So instead of closing like this, it closes kind of like that. So you have the area where the blood can actually travel downwards in opposite direction. And this is known as a reflux. So if you've ever been to the vein center and they do that ultrasound, what they're looking for the reflux. That's the blood flowing in the opposite direction where it's supposed to. It's not upwards, but rather downwards. So this is known as a venous insufficiency, and this is also happening in the lymphatics. Then, if you asked me several years ago what happens with overall lymphatics, I would say, well, they're not functioning normally, so they don't, in addition to valves not working well, the lymphatic system by itself is not kind of moving well. And it's kind of true, but now we understand that actual lymphatic system works over time, but it doesn't work as well. So let's say, hypothetically, if we're looking for lymphatic system pump everything out, the milking effect is going to be like this. So the muscles contract in sequential fashion. Now, in patients with lipedema, it's kind of more chaotic. It just kind of does one of these numbers. So as a result, it works more, but it really doesn't produce more result. As a result of this malfunction and malfunctioning valves, what happens is that the lymph stays inside of the lymphatic vessels. So it gets bigger and bigger and bigger, and the pressure increases. And remember, the walls of the lymphatics are very thin. So eventually, it's going to leak out back into the interstitial space, which is the space outside of the blood vessels. What happens there is that it has to go somewhere. It cannot be just sitting there as a lake. So it cannot go into bone, it cannot go into tendon, it cannot go into muscle. It really cannot go into nerve very much. And the only tissue it can go to is the fat. As a result, the fat becomes, instead of bright yellow, it becomes really light yellow. It's almost like a jelly-like. All the cells are increased and they accumulate all those lymphatic waste products. I would say 5 years ago, we thought that it was mostly proteins. Now we know they're complex carbohydrates. If you've seen or you've had any kind of cosmetic injections based on hyaluronic acid, that's exactly what it is. It's the complex hyaluronic acid type molecules that absorb water and becomes really big. And that's what happens in the interstitial space and in the cells. Now, the body realizes that these waste products are supposed to be back up, cleared out, and they're not supposed to be the interstitial space. So they need to clean it up. The body needs to clean it up. And the only way the body can do it is sounding universal cleaning an alarm. So the way the body does it, it has only one signal, which is inflammation. So the body sends inflammatory signals all over the body, and from all over the body, the cells that are responsible for cleaning things up and for inflammatory response are coming in. White blood cells, macrophages, T cells, and so forth. All of them come to the legs and try to clean all this stuff up. Unfortunately, the capacity, or it's almost impossible to clean it up. And as a result, inflammation lasts not a week or two, but years, if not decades. And what happens as a result is now the chronic inflammation starts affecting other tissues. So, for example, the chronic inflammation around the nerve causes partial resorption of the Schwann cells that are located on the outside. And as such, instead of giving you the sensation of touch, it starts passing you a sensation of pain instead. That's why you feel pain where you shouldn't, because the nerves are not functioning well because of chronic inflammation. Now, the metabolic level of metabolic activity because of the fat cells getting bigger is also increased. And the body needs more blood supply. So now the body has to build brand new blood vessels going into the area of all this lymph leaking out, so to speak. As a result, the blood vessels that are built, they're built through the inflammatory area, and the body does the sort of like MacGyvering, doing whatever it can. The blood vessels are built, but they're not normal. They are more brittle. So as they are more brittle, they don't bend very well. And a minor trauma, instead of getting the blood vessel to kind of bend in and out, it just breaks it. So now you have easy bruising. So hopefully you see all of it starts coming together. Now, remember, the problem is the fat accumulation, abnormal function of the lymphatics, and then also there's a possible third component is chronic connective tissue disorder of some sort. We think it may be related to Ehlers-Danlos syndrome, or maybe not, or maybe some components of it. But the idea is that the elastic tissues that's supposed to help with squeezing the lymphatics and even maybe the walls of lymphatics are more stretchable than normal. Fascia are more stretchable than normal. Skin is more stretchable than normal. And as a result, it doesn't create that countertraction or counterpressure that is required for the lymphatics to function normally. In addition to that, the joints capsule also has more stretchable tissues, and because the way the fat is deposited, it goes on the inside of the legs. As a result, people cannot really fully bring the legs together. They kind of walk a little separated with the legs in a kind of X-shaped fashion. And what happens is that the weight of the body is not going between two condyles of the tibia, but kind of goes toward one. And as a result, usually patients with lipedema and accumulation of fat on the inside of the legs, what happens is they develop early arthritis of the medial knees. And if you look at the way people with advanced lipedema walk, they don't walk with their feet like this. They kind of walk bare, like a little bit like this. And the reason it happens is because it's more comfortable for them. So the hip is slightly inverted. The knee puts the weight on the medial condyle, so on kind of on this condyle, and then the outer ankle is also affected. So people walk like this. That's the way they can walk. And you have arthritis in all three areas. And it's not surprising for me to see somebody who is 40 years old and they were already told that they need to have a knee replacement or something like that. Now, the reason I know it is because after I do liposuction surgery, suddenly a patient says, hey, I have no knee pain, I have no ankle pain, I have no hip pain, I can walk better. And I realize it's not just liposuction itself, it's the whole change of the way you walk. So you can bring the legs together, you can finally open up your hips a little bit more, and you distribute the weight the way you're supposed to rather than the way you kind of have to. Okay? So that's the orthopedic implications of lipedema. Now, let's talk about liposuction, of what it does. And initially, when I started doing liposuction, I would say 20-some years ago, and I think my first lipedema patient that I've done, I didn't even know that that was lipedema. That was probably another 17 to 20 years ago. I had this Asian lady that came in. She was really skinny on the top, really heavy on the bottom, a lot of pain. And I really didn't know what I can help her about because I was trying to do something good. I did liposuction. I removed a lot of fat, and she was very happy. The pain got better. I really didn't believe at that time she had pain. I thought she was just trying to find a reason to do liposuction, but whatever. And then I would say I became a believer in liposuction, in lipedema diagnosis, approximately 5 years ago, when I started seeing patients of completely different capacity. And I have to thank the patients for educating me on that. And from there on, I started reading and so forth. Now, but the question is, well, why does liposuction work? And we know it does, but what does it really do? How does it affect things? Let's say we remove some of the fat. Great. But if you believe that everything is related to inflammation, the question is, why would the nerves get better? Why would the brittleness get better? Why would all the symptoms get better just because we removed the fat? We really didn't affect the inflammation. We didn't affect the leakage of the lymph from the lymphatic vessels. So why does it work really? And I was struggling with that for a little bit. And as I was going through the process and doing the surgeries, finally I was able to come up with the answer. So here's an answer. And again, if you're a doctor, if you're a provider, you may or may not believe me or may not make sense, but just stay with me. Hopefully it makes sense. So here's the idea. Once we remove the fat, yes, we do remove extra weight. Yes, we remove some inflammatory cells, but we don't do anything about lymphatic vessels. But here's what we do. We create a thin layer of the scar tissue all around the leg. And the collagen that is formed is a different kind than the collagen that is affected by connective tissue disorder. Think of it as if we create an internal stockinette with a scar tissue all over the place. So usually the scar tissue is a bad thing, but I think in patients with lipedema, the scar tissue is actually a good thing, because what it does, it creates a countertraction. I think what happens is that as we create that internal scar tissue all over, because we eventually do circumferential liposuction, now the body has something to push against to make lymphatics more efficient. And that's what allows for better mobilization of the lymph, and that's what allows eventually for reduction of inflammation. At least that is my belief. So whenever I do liposuction right now for lipedema, I have to think, on one hand, what is the appearance is going to look like? And on the other hand, what is the functional improvement we expect? Majority of the patients that I see in my office with lipedema, they're not really skinny girls with a stage 1 that want to look a little better. No, I have usually the ladies above 35 with a couple of kids, and they usually have heavy legs, they have a hard time walking. Some of their family members may be already in a wheelchair or going toward the wheelchair. They see it's going in that direction, and they want to do something to improve or maintain their ability to ambulate. What also I can tell you is that those ladies have been turned down by multiple people, and after they have the first couple of surgeries, after they're able to mobilize themselves, it's remarkable how much their lifestyle changes. I have a lady that I did 2 surgeries. I think I removed altogether about 20 some pounds from her legs, and then she lost over 50 pounds of her own. And she says, I really don't know how it happened. I was kind of just a little bit more active. I felt like I can walk more, I can do more, and suddenly just the weight is gone. And she's not the only one. So I think there's more to weight loss or more to ability to lose weight in lipedema patients with liposuction. I remember many years ago there was an article that promoted doing liposuction in bariatric patients. I know it's kind of a no-no, but the rationale was that we have a white fat which is located on the skin, under the skin, and we have a brown fat located inside of the abdomen. And the brown fat is the most difficult to lose. So when the patient loses weight with bariatric surgery, they usually lose white fat and not as much of the brown fat. But the question was, several articles came out that said that if you do liposuction before, you decrease the body's capacity to eliminate the white fat, so it focuses on the intra-abdominal brown fat. I don't think this article really struck my attention at that time, but now, as I'm dealing with lipedema, I kind of look at it slightly differently. What kind of liposuction is available? There's a separate video available that I filmed together for different types of liposuction, but let me kind of quickly go over it again. So first of all, the preparation for liposuction involves putting tumescent fluid into the tissues. So tumescent fluid is a combination of saline solution to kind of blow up the tissues. It's lidocaine to numb up the tissues, and it is epinephrine to shrink the blood vessels. And also sometimes we add bicarbonate to improve the function of the lidocaine and allow it to spread a little bit easier. So as a result, the leg becomes more swollen, bigger, the fat cells become more engorged, and the spaces between connective tissue also enlarge. And in my mind, as when they're bigger, it's much easier to remove the fat with liposuction when you have bigger space, and then you have less damage to the connective tissue, less bleeding, and you can remove more fat. So any liposuction that we do today involves preparation of the tissues with tumescent fluid. So any liposuction is going to be a tumescent liposuction, okay? Tumescent has nothing to do with the type of liposuction. It just has to do with preparation of the tissues. Now, if we take the hollow cannula, and the hollow cannula does not vibrate, it's connected to liposuction machine, which is a $20,000 vacuum cleaner in essence. You move it back and forth. It has several openings on it. And as we move it, the fat gets trapped inside of the openings. And as we continue to move it, we kind of rip it out, and it gets sucked into the liposuction machine. So this is known as if the cannula does not vibrate, it's known as a standard or traditional tumescent liposuction, okay? Now, they came up with a different system where the cannula vibrates, and it can vibrate in two ways. One is it goes a little bit back and forth, and the idea is it helps to easier navigate through the connective tissue, creating less trauma, less pain, kind of with this kind of vibrating effect. And the second option is when it actually turns around its axis, like semi-screw, kind of goes through the tissues. And what it does, it allows to more of an even removal of the fat, either circumferentially or back and forth. It also provides for the better ability to create a straight plane, easier passage through the connective tissues. And it really helps the operator, like myself or a surgeon, to use smaller cannula to remove more fat in a shorter period of time, hopefully with less damage because we use smaller cannulas. So one of those, when it vibrates back and forth, is known as the power-assisted liposuction. The one that rotates, I think it's called the Pure Sculpt, also part of power-assisted liposuction. And both of them are tumescent. because we prepare the tissues the same way. Okay, so that's the standard types of liposuction. Then, if we want to improve the result or improve reduction of the fat removal, reduce the trauma, then we can, on top of it, use what's called ultrasonic assisted liposelection. It's also known as VASER. And what the VASER is, it's an ultrasound machine that has a probe that's placed underneath the body. Remember, it's not the liposuction cannula, so it's not hollow. It's a solid probe with 3 rings on it. And it's done like this. We make a little opening, we do tumescent infiltration, then we put the the probe in and move it back and forth. And initially you have to kind of push it because there's a lot of resistance from the tissues. But as the tumescent, I'm sorry, I'm getting a little over the big. As the ultrasonic probe gets into the tissues, it shakes the fat cells, and the frequency of the shaking is tuned to the frequency of connection between the fat cells and connective tissue. I think one of the ways to explain it is that if you take a look at a small apple or orange tree, for example, you come in and you slowly move it back and forth. The whole thing moves back and forth. Nothing falls down. You shake it violently, you'll break the tree. But if you find that specific frequency where you shake it at specific frequency, the branches are still going to be okay, but the fruits will fall down. This is known as a resonant frequency. And every structure, every building, every bridge, even the human body has certain resonant frequencies. So there's nothing unusual for the fat connections to have resonant frequencies too. The technology is close to about 25 to 30 years old, and we've been using it for many years. And what happens is that after I'm moving this ultrasonic probe back and forth, it shakes the fat cells, separates them, and actually you look inside and you see all those empty places, and the fat kind of goes down into with the gravity into the bottom of the wound, and it turns it to the substance that kind of looks like buttermilk. And at that point, I can take my liposuction machine, and remember, I don't have to now remove the fat with high power suction. I can turn the suction down, and all I do is kind of mop the floor from that buttermilk substance. As a result, I can use smaller cannulas, smaller suction, and it creates less damage. And when I do treatment for lipedema for patients with ultrasonic device and without, I definitely see much faster healing, much less bruising, much less swelling with that ultrasonic device than without. And sometimes I use what's called a boomerang technique, which is you do ultrasound treatment, you do liposuction, you do some more ultrasound treatment, some more liposuction. And the idea is you do it not even in one direction, you do it from multiple directions. You kind of cross-hatch. As a result, you can get more of an even plane. In patients who do not have lipedema, we have studies to show that ultrasound device like VASER provides additional skin tightening. I don't think there is a study to prove that it does the same thing in lipedema patients, but at least a reduction of swelling, bruising, and faster recovery, I definitely see. There are some questionable reports about some burns associated with VASER, and it all has to do with the way you use technology. So it's just a tool, just like a hammer. You move it back and forth, you cannot stop, and if you stop, you really have to turn it off right away with your foot. And if you kind of pay attention to somebody else, or somebody's talking to you, you cannot just stand there and answer the question, because you just create the burn. So it all has to do with how you use the tool. It's not the tool itself. The only problem that I see with VASER, it's not recognized by insurance companies as approved modality. So if you want me to use VASER, usually there is a small upcharge for additional time and utilization of the device that we have to bring in specifically for your specific case. So again, so now we have power-assisted liposuction with VASER or ultrasonic device, and that's what majority of the surgeons that I know use. Now, some of them also use on the younger and smaller patients some skin tightening devices, like Ultraslim or J-Plasma or Renuvion or one of those. We are working with the companies to see what kind of results they provide. But for the patients that I see who are significantly larger, I don't think a little skin tightening justifies additional expense or creates any significant improvement of the result. Now, a separate category of it is a water-assisted liposuction. It's more popular in Europe. It's less popular here. Some doctors do it here, and they like it. I tried it. I'm not really a big fan of it. I'm not saying anything is wrong with it, but here's my rationale. If the doctor is doing smaller volumes in the office, water-assisted liposuction is a very reasonable choice. You can do the surgeries more often. It's easier tolerated and so forth, but you need significantly more surgeries. And then if I need to remove over 5 liters, which in my case, most of my patients require over 5 liters removed, it's really hard for me to remove that much weight with water-assisted liposuction. In addition to that, if I have to do removal of the skin at the same time, it's really challenging, because when we do liposuction traditional way, we put the fluid in, we suction everything out, everything shrinks down, and I can see how much extra skin we have, so I can take it out. With water-assisted liposuction, you put the fluid in as you remove the fat out. So really the size of the extremity doesn't really change very much, and you can't see how much extra skin is out there. So to do skin removal, you have to let the swelling out and then go back in and remove the skin. Just common sense, that's all it is. Again, great technique. I'm not a big fan of it because majority of my patients are significantly bigger than 5 liters. I usually remove between, I would say, 5 and 10 liters per surgery. The patients usually stay overnight. I have patients who had 4 surgeries. There are patients who I had removed over 100 pounds from their legs. And to those of you who are providers and who are skeptical, and maybe recommend doing bariatric surgery before, I tell you those patients already had bariatric surgery. Most of them had most of them had at least 2 bariatric surgeries in the past, and 100% of them usually have sleeve gastrectomy prior. They lost as much weight as they could, and still the legs did not respond. Now, how do I plan the surgeries? Okay, obviously I want to address the areas that bother the patient the most. Most of the patients, I start with liposuction of the lower extremities. So I lay the patient face up, so these are the feet, hypothetically. So the patient is laying up, and I start from the ankles or wherever the lowest end of lipedema, and I go all the way up to the hip and slightly above. And I treat everything on the front, on the inside and outside of the leg as much as I can, going all the way up. I do not do circumferential unless I do only lower legs, meaning below the knee down. And I've done that for some patients too, because of the size. But most of the time I do this kind of horseshoe looking approach. And then the swelling does stay longer. There's quite a bit of bruising. The patients that I see, they're at higher risk for blood clots and pulmonary embolism. So we do have protocols to prevent those complications. And as a result, patients are usually, again, swollen a little bit longer. That's why if I operate on the same area, I usually give myself about 3 months to get the swelling down. Let's say 3 months passed, patient comes back, now we're going face down. And I treat the back of the legs, the inside of the legs, outside of the legs, buttocks going all the way to the back as much as I can. And at that time, if you understand, the inside of the legs and outside of the legs gets treated at least twice, during the first surgery, on the front and on the back. One of the most tender areas that I see on the patients is the medial knees, right in this area. And this is the area where sometimes I see those little lippies, as Dr. Schwartz talked about, once I'm done liposuction, and if I still see this kind of mushiness there that is not getting removed with Vaser or with liposuction, then I take one of my liposuction incisions, I extend them a little bit wider, and then milk things out if I need to. I do not do it on every patient because not every patient in my book requires it. So that's the approach to the legs. Then I also do the arms separately. If the arms are smaller, I can do liposuction and skin removal at the same time. Now, the skin removal can be done in several ways. A traditional way is to go from this side of the elbow along the midline of the arm all the way into the armpit and maybe slightly inside. The problem is that's where lymphatics are, and that's where the scar is the worst. So if we go about half a distance to the back, or about right here, that's where I try to make an incision so that the incision heals better. We have a little gap between the lymphatics. And the approach that I use is called an avulsion technique. So I'm really trying to preserve the lymphatics, deep lymphatics, as much as I can. There's also a technique of minimal incision where the skin just tucks in a little bit into the armpit. So there's a single horizontal incision in the armpit. There's nothing right here, but this is more for the milder cases. So for the patients who have a lot of extra fat on the arms, I would do it in 2 stages. First stage, I would just remove extra tissue and then let it settle down, then come back, remove additional stuff, and remove extra skin. For the patients with a milder disease, I can do it in a single stage, but I cannot use water-assisted liposuction. Remember, because I need to remove the skin. Some of the patients will have fat extending all the way into the forearm, so I'll go into the forearm. And usually I kind of space it around the legs also. Stomach is usually treated separately. It can be just liposuction or a liposuction with removal of the excessive skin. And as a part of our pre-authorization process, we request all the surgeries. Does that mean that you have to go through all the surgeries? No, you really do not. All it means is that we want you to get comfortable. And if at some point you say, you know what, I feel better, I don't want to do any more surgeries, we're all good. About the insurance coverage. Medicare at this point does not recognize this treatment as medically necessary, and we're having a hard time with it. The other problem is that Medicare has 7-year look-back period, and the easiest thing the Medicare can do is to accuse us of performing unnecessary medical procedures, and this becomes a federal crime. And that's why a majority of doctors that I know, they would not treat lipedema patients with Medicare through Medicare, and we're unable to do it too. Medicaid, in most cases, the same way, even though some Medicaids have approved lipedema surgery with us. Private insurances are different. Private insurances, each have their own policies, and their own policies vary. Cigna, Aetna, and United Healthcare, they do have written policies. Some of the Blues have written policies, some of them don't. And usually we have to have several components. We have to have independent evaluation by an endocrinologist or somebody like that, myself, and then additional testing needs to be done to provide objective information and objective justification for the surgery. I do also have patients coming in that kind of have very mild disease, and you have to understand that once we send the pictures to the insurance company and there's a medical director on the other end who's going to review the case, they may or may not approve the condition, and then may require multiple appeals, and then appeals to the outside entities that can overrule the insurance company. But the more appeals we're going to go through, the longer the process is. So that's about the insurance. In the meantime, you need to continue with your diet, continue with compression, continue with decongestive therapy, continue with exercise, and remember that this is a lifelong disease. Even if we do liposuction and we have a great result and you're feeling better, the pain is better, you're more active, wonderful. But the underlying condition of lymphatic malfunction and maybe components of connective tissue disorder are still there. So it's a lifelong process you have to adhere to. So hopefully it answers majority of the questions that I usually answer during the consultation. Please, we were pleased to see you in the office or via telemedicine consult. and hopefully it provides you the background of what we're going to be talking about or what we spoke about. If you have any suggestions of what you would like me to discuss in the future, we'll try to do it in a shorter format videos, because I think 40 minutes is quite a bit to look at me and listen to me. But otherwise, we'll break it into small pieces. Again, thank you very much for listening. We look forward to seeing you. If you're too far away and you will want to look for somebody in your local area, it's it's fine. Here's a couple things for the last thing to mention. If you're having high volume liposuction, the safety parameters are completely different. You cannot have it done in the office, okay, based on the plastic surgery requirements and state requirements. But beyond that, you have also safety requirements. The risk of blood clots and pulmonary embolism are higher. The protocols are somewhat different. The liposuction for lipedema is somewhat different than liposuction for cosmetic reasons. You have to really be aware of anatomy. You have to really use different cannulas above and below the fascia. And the protocol of compression and everything else is also somewhat different. So when you go look for a plastic surgeon who does it, please make sure that they're comfortable and they understand lipedema. If they're just doing liposuction day in and out, they may not be necessarily the best choice for you, even though they may be a great cosmetic liposuction person. And definitely make sure that they're trained and they have hospital privileges to do what they want them to do in the office if they're doing it in the office. So when you see the doctor, say, hey, do you have hospital privileges to do this? And if they do, chances are the hospital vetted them in their training and expertise and malpractice and everything else to perform this procedure. If they don't have hospital privileges and you have a complication, what are you going to do? You're going to end up in the emergency room and the doctor cannot come in and see you, the one that operated on you, and you're going to get somebody else who may not be familiar with lipedema. So make sure that the doctor who you see does have hospital privileges, especially if they do high volume liposuction. All right. And that's the last I wanted to say. Best wishes. Thank you for listening to me, and good luck with everything.